All right. Good afternoon, everyone. My name is Kunga Denzongpa, and I'm an evaluation specialist here at the Community Campus Partnerships for Health. Today, I have the honor to welcome you to our webinar, The Greensboro Experience, a Public Health Lens on Refugee Health Disparity During a Pandemic. In this webinar today, we will explore the structural barriers refugees face around COVID-19 prevention and treatment. We'll also talk a little bit about the current organizational and research supports provided to refugee communities in and around Greensboro, and then potentially describe ways in which community organizations and public health interventions can support refugee healthcare. Next slide, please. So a little bit about our organization. Community Campus Partnerships for Health is a 25-year-old organization that builds partnerships between academic institutions and communities to promote health equity and social justice. The picture that you see of the two gentlemen in the middle, the taller one is our executive director, Mr. Al Richmond. He has been a phenomenal leader for our organization who shares a strong passion on health equity and centering communities while leading this meaningful work. Next slide, please. So to talk a little bit about our approach to community engagement, when it comes to partnering, we believe that health equity and social justice only can be achieved through collaborative efforts. When it comes to trainings, we offer informed practices of community engaged research and building capacity among academic and community partners. When it comes to connecting, we bring together people from across the globe, just like today, to engage in discussions, gain new knowledge, think critically about their work, and take appropriate actions individually as well as collectively. So in the spirit of connecting our global reach, before we introduce our panel, I would just like to center this space today with an understanding that our conversations today have been enriched with local voices, right? So globalized local voices from our community who make up our panelists today. So just a sort of a disclaimer, not all our conversations today are going to utilize US-centric language or US-centric terminology, or maybe not even a US-centric lens, right? In fact, all our panel, including myself, are foreign-born immigrants with a global lens. So today I implore you, all of you, that you experience this space through reflexivity, by truly centering our panelists' narratives as their truth, because really our lived experience tend to shape our reality. So in spaces like this webinar that allows us to explore a diverse understanding of cross-cultural discourse, right? So I hope that you all are able to participate in this space by enriching in the discussion through a global cross-cultural lens. So with that, I will now pass it on to my colleague, Chamu, who will introduce herself and the panelists today. Chamu, take it, go ahead.
Chamu, you're muted.
Sorry. Hello, my name is Chamu Shanmugam, and welcome to this webinar. I'm an intern finishing my master's in public health degree from the University of North Carolina in Greensboro. I am also a late career pediatrician, and I've been working with underserved populations for more than 20 years. My interests are in refugee health, and my research focus has been on resilience in refugees. So a few years ago, I started seeing refugee children in my clinic, and it was a very new and enlightening, but still an engaging experience, because refugees have their unique set of health issues, and they also face a unique set of barriers accessing healthcare. Next to my photo is my son. His name is Karun Prasanna. And when I would see my patients in clinic, I would come home and share some of these stories with him. You know, I've seen people from all over the world, and they're telling me how it was to be in a refugee camp. He was around 10th or 12th grade, 11th grade, and he was completely intrigued. So he said he wanted to interview Greensboro's refugees with his iPhone, and he put together this community engagement effort to create digital archives. It's on Facebook, and it's called the Greensboro Project, Many Voices and Many Stories. Next slide, please. So the project is about cultural diversity and the richness new immigrants and refugees bring. This is Sokchit. She was born in a Thai refugee camp after her parents fled from Cambodia to escape the Khmer Rouge genocide. And here she's performing a Cambodian peacock dance at the Buddhist temple in Greensboro. Harun asked me to help him, so I went with him for every refugee interview. And something about our dynamic, I guess, as mother and son, him getting annoyed at times was relatable. It would make people smile, and conversations would then flow easily between them and my family. Next slide, please. Previous one. Yes, thank you. So like this, we met over 150 refugees from more than 25 countries. We also met refugees, resettlement people. And the thing is, we would meet them in their setting, in their homes, their temples, sometimes at a dance class or a cooking class. This was another enriching experience because for me as a clinician, I was now seeing dimensions way beyond the clinical interface. I was seeing cultural mores, their attitude towards health, illness, and wellness. I was seeing their living conditions in low-income housing with overcrowding. I was seeing the pest infestations. I was also seeing the kind of food they eat, what they would shop at in the Asian grocery store in Greensboro. And all of this, you know, it educated me more. That's when I decided to follow my passion and I enrolled in the Master's in Public Health at the University of North Carolina in Greensboro. Now, if you look at these photos, this is just a few of the refugees we had interviewed. A lot of them are smiling, and that's a reflection of no matter how hard their life has been, they have survival strategies for resilience, and that's been my research topic. Next slide, please. So Greensboro has been one of the first cities in the US to start refugee resettlement. It's been a leader in refugee resettlement since the 1980s. We've been hosting a diverse refugee population. This gentleman is Dr. Raleigh Bailey. He is a national refugee resettlement expert, and he's part of the University of North Carolina in Greensboro. He started this place called the Center for New North Carolinians, through which many programs are available for refugees. If you look at this globe and the map, the first set of people came in the 1980s from Vietnam. They were people who lived in the mountains, and they're known as Montagnards. Montagnard is a French word for mountain people because that area of Vietnam was formerly French territory. You see, the Montagnards had been helping the US armed forces during the Vietnam War, but after the war, they were being persecuted by the communist government of Vietnam. And the US veterans, you know, as a gesture of gratitude to the Vietnam people who helped them, they asked the US government if they could be brought over to the US. So this way, we started helping people who had helped us. And since then, many refugees from many countries have been coming to Greensboro. By no means are we the only city that's resettling refugees. Now there are lots of cities all over the US. Cambodians also helped us in the war. So they came to Greensboro around the same time as the people from Vietnam, the Montagnards. But they had a lot of mental health issues because of the genocide that was going on in Cambodia under Khmer Rouge dictatorship. We gave them mental health intervention, but they were not effective. So Dr. Raleigh Bailey, he asked the Cambodian community, how can we help you? And then they asked for a place to worship. So my university gifted them a house, which is now a Buddhist temple. It is a safe haven for them for finding peace and reflection. And now it has become an active hub of cultural activities. I showed you the picture of the peacock dance earlier. You see, spirituality and cultural preservation they both help build resilience. Greensboro is known as a welcoming city. We have an engaged and active community with programs for refugees and community resources, such as free classes for setting up businesses and microloans. We have this unique place called the Newcomer School, which is for children who have just arrived so they can learn English and learn how to adapt to the new culture and society. And then they go back and tell their parents how to do this. Next slide, please. I'd like to share a few unique barriers that refugees have faced that got worse during COVID. So even when you know English, it is very difficult to navigate the multiple systems in the US. So imagine how much harder it is for refugees. Multi-generational families are common in Asia and Africa. But when refugees are resettled here in small, crowded houses, the older people are exposed to COVID because the younger ones are going out to work or they're going to school. The other thing is social isolation. They've already left their family and home when they had to leave their country, and they feel social isolation and mental trauma. But add to this the COVID lockdowns, the physical distancing and quarantine, the social isolation gets more and adds to their mental problems. Now, data aggregation, that's a big one. Here's the thing, all Black people, whether they're from Africa or they're local African Americans or they're from the Caribbean islands, they are all classified in the Black racial category. And similarly, Southeast Asians are classified with Native Hawaiians and Pacific Islanders. So does this make sense? Because when you aggregate data like this, it's hard to figure out which demographic has health advantages. And if you do a literature review, you're going to find very little data on COVID mortality rates and morbidity rates in refugees. Fear. Fear is something refugees suffer from. They're afraid of their immigration status has become unstable. They're afraid if they have COVID that they will lose their jobs, so they don't get tested. Next slide, please. Let's go through an algorithm of how a refugee responds when they have COVID symptoms. All the words in the round circles are if they do proceed. So that's the ideal path. When they ask themselves, do I have COVID, because they have some symptoms? They get tested and then they may fall ill and then they decide it is worth going to the doctor, so they get treated. But let's look at the default, which is lower down. They have symptoms, but they want to ignore it. That gives an appraisal delay. They ignore it and they get sicker, so that's an illness delay. And then they decide they don't want to go to the doctor because they don't know if it's covered by insurance. They don't have the money, even if they don't have insurance, and they might lose their jobs. So that is utilization delay. Next slide, please. So with all of these barriers, how can we overcome this? Starting at the bottom, where at the federal level, data disaggregation. Making the communities, host communities resilient. Helping refugees become self-reliant, and using collaborative thinking, such as design thinking, with the community members, the refugees themselves, to come up with health education programs, because those have been proven to be effective. So this is where I end, and I'm going to introduce you to my panel of speakers. First, we have Mr. Millian. I met him with Karun about 4 or 5 years ago when we interviewed you, Millian, at your office. Please take over from here. Thank you.
Thank you, Cham. All right. So my name is Mekennon. I'm the executive director here at North Carolina African Service Coalition. We are one of the resettlement agencies here in Greensboro. And we've been in the community since 1997. So I'll give you some of the breakdown. What we faced in resettlement at the time from 2017 through the COVID time. Next slide, please. So the resettlement during pandemic, it was not just, the change in the administration, and at the same time, we've been hit by the pandemic. So it was paused during that period of time. But before even the COVID, actually, the resettlement went down drastically from the previous physical years. The arrivals were predominantly Congolese coming from different parts of Africa. And as usual, travel was arranged by the International Organization of Migration that has a contract with the State Department. Refugees were screened before they travel, and they've been, if they have some kind of symptoms, they'll be isolated for a week or so before they even board the plane. I mean, once they've been cleared, they would have been provided with a thermometer to monitor their temperature during travel. And upon travel, we will isolate them as well for a week to 10 days to monitor the situation. And most of them actually during that period of time, they were coming with this thermometer, but if in case they didn't have one, we would give them right upon arrival at the airport. Next slide, please. So this is really, I mean, you know, I would like to give you the glimpse of, I mean, you know, the resettlement. It was in the highs, I mean, during the 19s, and you can look at where we were in the 2018s. So most resettlement agencies actually shut down the door or actually be drastically minimize their size. So it was at the maximum around 2017 or 2016. But after that, we hit really, I mean, you know, trailing behind other countries. The United States is actually the largest resettlement country around the world. I mean, you know, all others been summed up. I mean, you know, cannot be even close to the United States. So as a resettlement agency, we resettled about 25 individuals in the fiscal year 2018, which was really a very tiny number. I mean, we're not really, I mean, talking about the numbers. Actually, we've been serving people, and we were so grateful, even, I mean, you know, serving that many people during that period of time, while we had, I mean, really struggling with the pandemic and struggling, I mean, you know, to maintain our infrastructure. And so it was a very challenging time, not only because of COVID, but also, I mean, you know, with the administration, I mean, you know, going through that period of time for most resettlement agency. Next slide, please. So refugees are eligible for Medicaid for up to 8 months upon their arrivals. It is up to 8 months. I mean, you know, if they have been employed and get access to health benefit from their employer, that benefit, the Medicaid benefit will be ended. But the maximum they can be eligible for up to 8 months. And beyond that period of time, I mean, you know, they either be getting health insurance through the marketplace or otherwise, I mean, you know, from the community sources. During that period of time, the only employers were, I mean, you know, the food processing industries, but eventually, I mean, you know, right now it's expanded to include more employer in the area. We did not have any issue, I mean, you know, finding a job for England. We have a great partnership with a lot of employer around the area, I mean, to able to place comfortably clients. But back in 2017, 2018, it was a very challenging. We didn't have even that many people arriving as a new arrival. We've been mostly working with the existing refugees who's been here for some time, but the majority was being hired in the food processing industries. We've been assisted from HHS on providing PPE to able to provide for our clients and to the community members. And we've been out there aggressively to make sure, I mean, you know, individuals have this information, they not be ignored or they not be, I mean, you know, forgotten. So we'll be reaching out to every one of them, making sure they have the information, they have the PPE to able to really secure themselves and protect themselves. During that time, we also been provided with funding. The COVID funding through that came through the city, been dispersed by the United Way to able to really make sure, I mean, for those people who've been staying home and now working or sick, to able to be assisted with rent assistance, utility assistance, and providing food. We've been providing this regularly for up to 6 months during that period of time. Next slide, please. So what was the challenge during that time? I mean, just like every other organization, and we really been struggling to maintain the infrastructure. And our target was, we knew that we would come out of this situation, but how we're going to really maintain this infrastructure? Because resettlement, you can't really bring people today and start working. You have to have that experienced people, passionate people, able to make sure, I mean, continuously providing that service. So that was the issues that we were struggling, and to keep the staff member around and making sure we will come out of this situation. I mean, so that we can able to provide case management or other services. And most actually would be really missing due to illness. And clients have an issue. There was a transportation issue, moving from one place to another place, and even access to the health service. Most refugees also, they've been really hesitant, reluctant, I mean, to get tested if they even have symptoms, and lack of information in a different language. And some of the clients actually, they don't even write and read in their own language. So they have to really depend on, I mean, hearing. So finding that video or information in their own language to be able to communicate about the COVID also, or a challenge. The other was the mistrust was there, misinformation was there, and the stigma was there. And it's really, I mean, even during the end of the time, I mean, they'd be required to get tested, but they couldn't be really sure who's paying the fee for the testing, even though they were not really required to pay, but they were asking for the insurance, which they didn't have insurance information. I mean, so that really holds them to go out there and just get tested, and as well as, I mean, getting the vaccine and the boosters as well. Next slide. All right. With that, I will introduce you, Mr. Juma, who is a community leader and been living in Greensboro. Mr. Juma, take it over.
All right. Thank you for inviting me just to join this community. This is for how to develop that is can make us safety as a refugee. Since we came in America, we were fled from our homeland due to the ethnic cleansing. And we go to the refugee camp, stay there for a while, and we work as RCC, Central Committee for Refugee. And we see a lot of obstacles that is facing the refugee crisis, especially from the beginning of fleeing the home to reach where we are right now. And some of us, we reach here in America, we see a lot of problems crossing this refugee in different countries, which are getting resettlement to the United States. The first crisis is that the medical problems, emergence, and that was the beginning since we came. The thing has been declining due to the services because of the support from the organizations that can get access support from finance or to get involved into the material that can be host to the resettlement people, those they are coming from out and to be here. The second is that is the coronavirus that is occurred in 2019. That was the real communicable disease that is killing a lot of people and is still killing people. So to control is that kind of, it needs to be vaccinate some people, and other people, especially we as a refugee, we are in different directions. We get segregated due to the forms that we get it in the hospital or somewhere else. But unfortunately, the thing is we get it based on the vaccination on the side of the COVID-19, we get that there is some kind of racial discrimination based on there, because when you go to get the vaccine, you may get it that is there is which are you black or you are red or you are Asian American or whatever. That is make me as we as a black people, we have a doubt on that. On behalf and in addition to that one, we have another form based on the social medias what we getting around the globes. That is we get, especially there is the innocent people. We as a black people, we are too much innocent. The people are targeting us in different directions. And I have some of the videos that if possibility, I can even tell you that you can listen by your own. If there is
Juma, sorry for interrupting. Yeah, we will play the video. Is this the one where you heard on TikTok through social media?
No, that is a way that I hear that is it is a lot, but the specific that is make me too hard, and I feel that why we as a black people on earth, what we do for the people whom they are against us. Since the starting of the slave trade, and now it's 400 years and more, either we go to the Asia or we come to the Africa, there in Europe or just America. They couldn't able to work by themselves. They come and buy and they come and take the slaves and come and work with them because they know that they can't work alone. So here, why they are saying that to creating a synthetic molecule that can kill a African people.
Okay, we'll play the TikTok so people can listen, Juma. This is the one you shared. Sharice is going to play it. Sharice?
You have, I send, I don't know if you.
Right in suggesting that.
Okay.
Yeah, I can share it. Hold on.
Medicine, by definition.
Juma, hold on. We're sharing it from.
Which
hold on. Just turn off your phone. We're going to share it from the. From Sharice. She's going to link it. Okay.
Black people, this is just for you because this guy's admitting to the fact that governments are trying to exterminate you.
Where does any synthetic molecule serve the living?
They don't.
Right.
I mean, none.
And am I right in suggesting that a medicine, by definition, is something which contains synthetic molecules, something that is registered, patented, and put into the market as a medicine?
Absolutely.
Proper. Right. So what I'm learning from you, Dr. Young, is that a quadrillion-dollar enterprise is at work amongst us, decimating, culling the human family.
Intentionally.
Intentionally, using synthetic molecules, which by design are cancer, AIDS, all of the bogeymen we could dream up.
Yeah, it's for the purpose of sterilization and population control. There's too many people on the planet we need to get rid of. In the words of Bill Gates, at least 3 billion people need to die. So we'll just start off in Africa. We'll start doing our research there, and we'll eliminate most of the Africans because they're deplorable. They're worthless. They're not part of this world economy. So they have their rights taken away, and they're suppressed, and they're...
Black people.
So thank you for sharing this, Juma. We are going to let people interpret it. Now tell me, have you had the COVID vaccine yourself?
Yeah, I myself, I have a COVID vaccine. Since I got to take COVID vaccine, I was not just willing to take it, but due to the obligation into the workplace, because you know that we don't have the source of income. Our source of income is based on to the workplace. And that workplace, when you go and they say that if you don't go take a vaccine, you are not going to work. And we know we don't have a house, we don't have no electricity at home by our own, or we don't have a business place our own. We as a refugee, we came here just for the safety to work and do, but we get here, another obstacle is that is make us, we must go and do that things. Unless if we don't do it, we don't get it. So I get obligated to go and take it. I took the vaccine, the first and the second. So it make me hard. Even my neck right now, I cannot move it hard. You know, my neck is getting harder because I believe that this thing is not really that even the most of the group into the workplace, in the schools, and on the restaurants, the most people we meet them, they are talking this kind of disease is not a good because these people whom they are economically strong, especially as those whom they studied early. Example, like we have, since the slave trade started in being in America, some people, they go and invade the Africa, other places. They already just gain a lot of minerals, a lot of financial, just they have already accumulated everything. So now they got a threat on that. They are not working as hard as we are working on the workplace. They only simply sit at home. They are thinking how to control these people, how we do to these people. But we are busy with working. You know, that is make me just, I hear a lot of things around. People, they want to just reduce us. People, they want to kill us. People, they want to do this one to give us an injection. They want to just make a wall around America that nobody can move. So they want to, just there's a lot of information coming is that doubt that even we are looking like today. I'm in America is not like safe like I was in Africa. You know, America itself looks to me is on fire. You know, I'm really have a doubt on it because everything is based on TikTok today is coming up. That's why they want to ban even the TikTok. Due to this, it's like a secret thing that has been keeping long ago is coming up. Now they want to ban the TikTok, and that is the one reason. And some of the reliable information that to come to us, they used to cut off. You know, they eliminate, they do everything is what they want to do. So we don't know what we're going to do,
So
especially
Juma,
black people.
I'm sorry. Juma, tell me all the sources of information like social media, TV channels. What are the ones you watch and listen to?
Okay, I used to listen to CNN.
Okay.
First, this is my favorite one. Second, Fox News is against CNN. I used to just try to correlate what is going on because Fox News is mostly, it's not general, it is a specific side. It's a linking with the super white supremacists. That's I absolutely know without any doubt. So we go to ABC. We have CarMax. Yeah, there's a local news I used to connect with, and we have a Facebook and Twitters. We have sometimes messengers also. I have a messengers if you can get a different place in different connections. And also TikTok is also the same. And we have WhatsApp and the others. There's a lot of things across. I can get the information.
Okay, I'm sorry, go ahead.
The another media that I used to get it is from direct collection from the source where I get it. That is already put it there, but the human being by himself surrounding me at the workplace, I can get that information. At the market, I can get it. And also the papers that comes through the mail, I used to get it. And the organization is, since if I go to the organizations, yeah, of course, I used to get it. Since I go to the African Service Coalitions, I used to get information there. They put there on there and everything is there. You can read it. There's some information based on COVID-19. Just we gotta take care of it. And also some vaccines. I get different places.
Okay, so you're saying that you get it from social media, mainstream media, and also local community within Greensboro area. That is from the coalition services that Mr. Million is from, and you're getting it from the workplace, your children's school. So you are getting the message and you're balancing the information from wherever it's coming, and you're coming to your conclusion based not only on the information, but also based on your own experiences.
Yes, sure.
Okay, so is there anything else you want to share before we let Ms. Satta take over?
Yeah, I want to share based on to the community leaders of whom they are here. I think most, almost maybe 50% of us we are representing here today, just maybe some people they experience based on to the refugee side. When they were a refugee, they know how the refugee they are getting painful. And when they come here, they came here for the safety and for the economical purpose. Just you know it when somebody come, just you get to just receive as a host, or you as organization, the managing these people to be relocated in some places. Please try to make things equally, not just segregating, or just because we see there is since we came, we see that the Russian refugee, the Asian refugees, especially like Syria, Iraq, and those who they are coming in Africa, they get different treatment. This is make me mad. Why this happening? Because if you come in Africa, you will not get a new staffs. You get all staffs, and when you come to the Syria, you get a new staffs. We don't know. We are thinking that maybe Syrians they are paying the money more, or due to what they are color is light color than the dark color. That is, I'm thinking there is systematic racism even within the black themselves too, you know?
Okay, yeah, I agree. So, Juma, I will have to continue this conversation by just between you and me, and I would like to talk about some of the media you've been listening to, if you're okay with it, after the webinar. But thank you for sharing your insight. It's been very valuable for the people who are in the audience, because a lot of them want to advocate for refugees. Thank you again.
You're welcome.
And now I'm going to introduce Ms. Satta. Ms. Satta is from Liberia. She came here about 9 years ago. She used to work with non-profit and non-governmental organizations in Liberia and with the United Nations Population Fund. Her work was with mainly adolescents with sexual assault and domestic violence. She left Liberia when the Ebola epidemic broke out, and her husband was still there. So when she started working with COVID and the refugee community, she was kind of familiar about what kind of work it requires. So Satta, will you take over here?
Thank you so much. Thank you so much for that introduction. Before I start, I will ask everyone just to give me a moment of silence for those that lost their life from the virus pandemic. We say COVID, especially where information was not the information we have now. We never had that information before. So if you can just give me if we can just have this 1 second of a moment of silence, remembering everyone, especially immigrants and refugees. Thank you. Whereas the speaker here said, I'm from the Liberian community. I moved here in 2014. Prior to coming to Liberia, I worked with different organizations in Liberia. I worked as a administrative assistant and a news reporter, also serving adolescent girls in Liberia with the Anti-Girls International Center. Moving to America and then volunteering in the community, I have already started this work because of the passion of serving my community. I started to help volunteer my services with the international community. So in connection with the Montagnard organization, helping community members. So I was not strange to what I saw with my experience with Ebola in 2014 in Liberia. Next slide, please. I currently work as a community health worker with the Montagnard Dega Association. It's strange having an African woman working for the Montagnard. So it just shows that how immigrants, we are all from different countries, but we are somehow connected. We have similar problems and we have to address these problems. It has to be a collaborative effort. Next slide, please. I would just highlight on a few goals about MDA for short goals. MDA, the mission to unite and strengthen the Montagnard community. Our first speaker highlighted a couple of things about MDA, the Montagnard from Vietnam. And the most interesting part is that we eat almost the same food. They also have their goals are cultural preservation, health and social services, which of course, and COVID vaccine outreach, where I work on similar projects within my community. And the Montagnard population, especially the elderly, so 70% of them are like clients from the Montagnard community, where you have the veterans. If you go back to history, and the speaker highlighted that they have most of them in the community. And then MDA, the organization, this nonprofit organization is actually to help their clients to be able to navigate this system. You talk about to increase vision through partnership, research with all community members. And they don't discriminate. This is why you see me today. I'm doing presentation as a community health worker from them. They are open to everyone. They partner with various organized community members. We talk about the Karani community, the Cambodian, the Liberian Swahili speaking community. So just to highlight, as a community health worker, working on the health and social service access and also COVID vaccine outreach, MDA was opportunity to have a grant they have with the Health Together and also with Partners in Health. Later on, and then was granted a lot of funding to be able to help with ACA enrollment and also help with food stamps, public assistance, help with COVID vaccine outreach. Next slide, please. So working with immigrants and refugees, we have these are the challenges that we face in our community, and we try to minimize them because it's not 100% eradicated. They all intertwined. It's not just about COVID. It's not the issue of COVID. You talk about case management. There are different parts of COVID. It's a long string that everything intertwined. It has to work together. They work together. So we have, on the first slide, we have mental health issue. As you may be aware, when you talk about, we have mental health. COVID is they are highly interrelated. If you are affected by COVID, one thing, immigrants and refugees, first of all, they cannot work. They have to stay home. Their kids have online school, and parents, you have language barriers. They cannot navigate the system properly. Parents have to sit home to be able to help their children to navigate the computer. Most parents are not computer literate. These are some of the challenges, and the husband have to go to work. And sometimes even the income is not enough because the mom stay home, because two is better than one. And the two income definitely will be able to help with the household activities. And it's a serious mental health issue when it comes to those things that refugees and immigrants experience to coordinate different activities. And the misinformation about the vaccine, making community members indecisive how to make decisions. During the COVID pandemic, you may experience stress, anxiety, fear, sadness, because first of all, you have different information. Family members telling you don't have to take the vaccine. This vaccine will kill you, or this vaccine is not good. You watch the news, you watch the TV. So there are too many information coming for you to be able to take. So community health worker within this area, this is our role to be able to educate our community and food insecurity. During the process of COVID, one of the challenges that when you tell people, I want you to register to get your vaccine, first of all, they will come to you with all the different problems, and you have to solve those problems bit by bit. And in order to solve those problems, you have to be knowledgeable about what you tell the clients. So what good thing that MDA have was that we have incentives available. We distributed food during vaccine clinic. We gave transportation incentive for them. And then we also have this full fresh vegetable distribution that we usually give to our clients. So
something that is
So we gave these, and we make these donations to our immigrants and refugee community. So when we get these fresh produce, we bag them, we drop them. I personally drop them, and then one of my colleagues, the entire team, drop it. We give it to the elders in the community as well. And we also, if you look at joblessness, we look at housing. During COVID, as COVID still housing is one of the major issues in North Carolina, and then we have the pandemic. So if you have one income and you have somebody affected by COVID, sometimes you notice most of our refugees and immigrants in the community, some of them, landlord will increase their rent. They cannot be able to afford. We talk about MDA also help those that have been impacted by COVID with funding that we already have, private funding. We help them pay a one more rent. We also help them pay utility bills for them. This alone encourage them to get vaccinated. And then we have the joblessness issue. We also provide, we have employment specialists in the office. We follow up with them. These are one of the things that we always keep track of our clients and our immigrants and refugee community, because we have the issue of language barrier. And one of the things during COVID that was quite, I will give you a story that was really terrifying. When we have the pandemic in 2020, everything was locked down. You have international students, you have people, immigration paper was, but it's just completely stopped. And USAID has a bylaw that you cannot even access your document. So if your work authorization expire, you have to wait. So this also contributed to the problem. So the issue of COVID is huge. It was huge, and we have to settle this problem bit by bit and encourage community members. Get in the community, we identify the issue of COVID. This is good for your health, but no, I have this problem. This is my problem I'm going through. I need help. So the situation becomes to be overwhelmed, but with the help of our private funding that we have, we were able to minimize and help community members with some of these. Next slide, please. Strategies to improve COVID prevention. So this was one of the amazing things. MDA, based on our funding, we have PPE supply. We'll ever have vaccine clinic. We had a mask for all of our projects, all of our activities within the community. We were able to complete the milestone. Our first project was able to serve, we have a target to serve 300 community members, 20 community health workers, and also volunteers. So we met that particular milestone, and we give information. The strategies that we use, we still educate community members, and while we were able to, we will reach 1,100 community members through WhatsApp, text messages, social media, every event. We make sure to create flyers. We post it on social media, because one thing I observed within the immigrants and refugee community, we use WhatsApp a lot. So all the different communities, they have different associations. So we send these flyers. We send these flyers to these different groups, and then that's how the information got out there. That would be a word that we have a vaccine clinic. We post it on social media, and we have you to sign up prior to this vaccine clinic. So, and we also have town hall meeting. We have town hall meeting with community members, with all the different community. We make sure that we educate you. We say we have this vaccine clinic coming out. Can you sign? And we give you your first dose, your second dose, a booster. We partner also with other organizations and other community members. So we have my family. She has always been there with MDA. Whenever we have our vaccine clinic, we have the contribution nurse. For Coon Health, they are one of our partners. And one of the things is trust. Actually, they trust people that they can talk to. Because we are, as for me, I'm a Liberian already, I'm an immigrant, right? And I understand how this works. The moment I start to talk to you, I will tell you my story. I tell you my story. Oh, I have been impacted by COVID. I had COVID before. And one of the things I will share this story with you, I used to work with a health facility at the time during COVID, and I got COVID. What happened? I couldn't go back to work. I had to stay home. And I had my daughter with me. I had my husband with me. It was so terrifying that I had to sleep in another room. I didn't have means to get to a hotel. And these are things that other people encounter. And basically, these are things, once they encounter these things, and they have to trust you to be able to tell you. When people have COVID in 2020, some of them don't even want to tell you because they know what, if they announce it, they will not go to work. So we have to keep in the community educating people, telling them how you have to come out and say these things, we will be able to help you. And we talk about capacity building. We have town hall meetings, we organize meetings in churches. I remember when I used to go to all the different Liberian churches and tell them the resources that are available, the things that they need to know about COVID. And some of them were so excited, they said, oh, can you have meetings with us every time? These are things. And I look at community health worker as the experts because the people in the community believe in them, they see them every day. We speak the same language, we go through the same problems. So these are people, when they'll tell you, the experts from in the offices will not tell you, they don't know what is happening within the community, except community health workers or leaders in the agency as well. And we come to capacity building. Capacity building, one of the good things that is still ongoing that we have the North Carolina Community Collaboration monthly meeting, and which of course this was through the Health Together grant. We still have this network that provide resources to train community health worker. We have MTA hired an expert that was able to train community health worker, and we still do this. And then we also go in the community and train community members, teach them how to use the mask, how to use the PPE supply, what to do, how to keep washing their hands, how to get tested. We have COVID, that's the COVID test kit right now, we just distributed, we still give masks out. And capacity building, we also have the vaccine equity meeting from Partners in Health, which of course the Partner in Health is one of our partners with MDA. We still have an ongoing meeting that they give us updates on all the activities as it relates to COVID. So we build the capacity of community health worker, even with the youth. We have a youth group. Every community do have a youth group on an MDA, and then we have meeting with them, educate them about basic things in the community. What are those things they need to know? So vaccine equity meeting is usually held with everyone. We have a vaccine equity meeting. They give us update. They do everything, and they will be able to relay those information to our community. And community members sometimes joke with some of us. They call us like, you are our correction fluid. If they don't know anything, they come to community leaders or they go to the organization. And that's how we're able to navigate through the system to reduce what is ongoing. Next slide, please. And these are some of the test kits. We have the webs, we have the test kits, and this is one of my co-workers. That's my daughter over there. And usually I take her because I want for community member to feel that it is not just about you taking a vaccine. And this is one of our vaccine clinics. When I say you have to go and do your community service assignment. So if you go to school, you have an immigrant friend, you tell them, oh, I volunteer to a vaccine clinic. That's another form of education. Next slide, please. This is one of our flyers. We give our booster shot, and one of our partners, she will be speaking out soon. And this is one of our elders from the Montagnard community. And we have our partners down here. We have this community, the booster shot was organized by the Bhutanese community, one of our MTA partners. And you see Health Together, this is the Health Together project, and my pharmacy that has always been working for her. Next slide, please. And this is one of our community health workers, and these are young people. MTA also work with the young people to be able to, they serve as an example for the friend, and we exceeded our milestone. MBA awarded additional funding from the Department of Health. So basically, based on our work, based on the work that MDA have been doing in the community, we have been able to partnering with me from an African community. For me, I see it as a great opportunity to get out, to get my community out there, to get people to know that it's not just about a single just few amount of immigrants, but it's everyone issue. So, and we hope to see more, to be able to impact our community, the young people are the future leaders, and seeing people like us helping in the community, it motivates even community members. If I go to you and tell you, this is what I have been through, I have lived this life, this is what I've been through as an immigrant, you can do it, the opportunity is there, but building up our community, and we want for our partners or leaders in the higher up to listen to community members, to listen to the grassroots organization. The grassroots organization do more work, like the agency, they do more work. And these are things that we expect us to work to be able to reduce this. In the immigrant community, we need more attention. We need people to really look at the immigrant community because we contribute towards the success of this nation. And I'm excited that we had the opportunity to share our experiences with partners around. Thank you.
Thank you so much, Satta. That was very helpful knowing how you are working in the community and how trust is important because you have a similar background. People always ask for someone who looks like me. That's who they will listen to. And I thank you again. Our next speaker, I would like to introduce. I have the honor of introducing my professor, Dr. and Professor Sharon Morrison.
Thank you, Shamu. I'm both humbled and honored today to be on a panel with folks who I know, folks who I've heard about, and folks who have been and continue to be in the trenches. So thank you for setting the stage, and hopefully our audience gets a sense of the challenges and the hard work and the road ahead, because this is not over. That road ahead to continue to work with and support marginalized communities, such as our refugee communities, in their fight to life, integration, and just being in a space where they can look forward to having the next generation reap the benefits of their hard work and suffering. So on that note, next slide. What I bring to you today is the perspective of partnership and partnership building and utilizing longstanding partnerships, which are important for us in this community. And so I bring the campus refugee community partnership and engagement perspective and look at today how nurtured and cultivated partnerships between refugee origin communities and higher education communities and their stakeholders and higher education institutions can collaboratively work and bring change, leveraged response, and impact lives in positive ways. COVID offered us an opportunity to put our mouth and our money in the same place. And it anchored us in such a way that it offered the next generation an opportunity for an immersive experience. Next slide. So let me bring your attention to an email communication from a frontline provider within our area health system to the executive director of a longstanding local nonprofit, which Satta represented very well, the Montagnard Dega Association, to its current executive director. This was a tragic call out for help And what is important to note here is that in that moment, the system that is supposed to be able to care for a broader range of individuals, a system that's often unnavigable, recognized its helplessness and in the situation and reached out to community insiders and leveraged their mobilization ability and responsibility to curtail higher than unusual COVID hospitalizations from refugee origin community. And what this email also highlights were the cascade and the complexity of the social determinants of refugee health. The race, ethnic, and cultural misidentity that often happens for groups. Hence, we've seen Vietnamese or Montagnard, they're often confused and unaccounted for in the data, in the system. This idea of social distancing, which leads to, as you know, further isolation. And the do not go to work, emphatic, that resulted in lack or loss of employment, which then resulted in economic security. The system saw the gaps and felt they could fill it and fill the social disparities that were painfully amplified by COVID. This email illustrates what we in public health deem a pivotal moment of social injustice and a lesson to be learned about the disengagement of marginalized communities from the care system. Next slide. So I come bringing the academic perspective based on more than 10 plus years, even 15 years of working with partners who are represented in this panel, working with two models. The first model represented it is a way that a university such as University of North Carolina, Greensboro, which is designated a minority serving institution, as well as highly community engaged. This model, Model 1, is a way of working with our local communities and our students who are our resources. So for example, we have community service that students can do, and to enhance learning, we also have what is known as community engaged scholarship, in which we are discovering and working together, writing about it, making and advocating about injustices, but also about the disparities. And then community-based participatory research. In that framework, we've worked alongside refugee communities and their agendas and their calls for support as they advocate and, dare I say, even protest for what is rightful when they are resettled in our community, when they are put in our economy, when they contribute to the diversity and cultural richness of the Greensboro region. So students become the capital and become the vessel through which we work with communities, faculty and students together. Model 2 is what we see when we now take students who belong to these refugee communities and see them as community or cultural insiders. And this is extremely important and why we were able to do what we did during COVID and continue to do. If you think about this, the campus community has a timeline that is rich, resource rich, a timeline that comes with breaks and is a community that is resource rich. The community, on the other hand, has a continuous timeline. It has all the issues that my colleagues ahead of me painted, and in many instances is seen as resource poor. However, with COVID, we were able to work with students as well as with the community insiders who attended our institutions and sat in front of us in our classrooms to address and respond to some of the COVID challenges. Next slide, please. So let me highlight some of the learning that happened and some of the responses and problem solving. First of all, we recognized that there were two critical issues. Satta alluded to the first, the issue of food insecurity. With lockdowns, job loss, social distancing, as well as movement as a result of losing housing, food insecurity pivoted to the top of the list. So my students and I, who represent the Department of Public Health, primarily the Department of Public Health Education, but from other areas too, worked with the Montagnard Dega Association, but also with the Bhutanese community. And also we integrated work with communities that were in our 27405 food desert to handle an important piece, rice. Rice is life for these communities. And that was one of the very first things that we had to do, was to recognize and address food insecurity. We worked alongside food banks to deliver food, pack and deliver food, nutritious food to these communities, to households who could not come out to shop. The second thing we did was to recognize, as health education specialists, the need for, and as Mr. Juma so eloquently put it, information. Where do we get accurate information at the end of the day? And so leveraging our coursework as we pivoted to online venues, leveraging our coursework towards meaningful outputs for communities. And so we developed informational pages on social media. We also used infographics, and we designed infographics and had the infographics translated in more than 4 languages. So we worked with 2 major Montagnard languages, Jirai and Rade. We translated into Swahili, and we also translated into Nepali language. Our students also stepped up to assist families during the holiday seasons. So during COVID, we celebrated 4th of July. We also celebrated Memorial Day. We also celebrated Thanksgiving. We also celebrated Christmas and New Year's. These are important points of social organization for our refugee community, many of our favorite refugee communities that got overlooked during the time of COVID, intense and emergent responses. And so we worked with students to be able to deliver food or presents or what we call check-ins with families and with their children. So 1, we worked with food. 2, we worked with information about where to get tested, where to get vaccines, PPE supplies, etc. The next thing that we did was work closely with our cultural insiders who were also our communities. The issue that Juma brought up, the issue that everyone brought up is trust. Trust. Who do you trust? You trust individuals that look like you. And so we worked through our cultural insiders to get messaging out, to answer questions, to deal with the racial epithets that came at communities when the broader narrative was that they were the cause of this virus. We also worked to bridge what we call intergenerational conflict, where elders wanted to continue to meet because that's how they socialize, and youth feeling that this was unsafe and tried to get the elders to understand why we needed to go virtual. We also saw that during this time, we had two crossover epidemics, COVID and racism, which again are ongoing. And so our students worked and became facilitators, and our cultural insiders became facilitators of dialogue regarding how best to advocate during a time of COVID and during a time of George Floyd. We also worked closely with the community, particularly the Montagnard community, who had already built trusting relationships with Liberian, with Congolese, with Bhutanese, to staff clinics. And so in our outcomes, or what we call our reciprocity, the community was able to support and help train up one of their own to also work with the Montagnard vaccine outreach initiatives. So we, in higher ed, utilize this opportunity to immerse our students with refugee communities, do cross-cultural and interprofessional training, and set the stage for how we will respond for future emergencies. Next slide. So what are the payoffs? For the community, we had what we call a cradle to grave higher immunization rate or vaccine uptake. For frontline workers, official recognition for their efforts, for the time and the sacrifices they made. For some, losing family members during this COVID period was very difficult, but they proceeded to help nonetheless. For our community, sharing organizational purposes among these refugee communities, better understanding of each other and their needs, and leveraging and leaning on each other's strength. And as Satta alluded to, learning about the ways they had cultural exchanges in which they have similar and not so similar cultural symbols. And finally, for the community, a higher uptake of vaccines, but also decreased food insecurity, housing, help to offset housing loss, as well as a better recognition by the system of the community and how community on the ground supports health and well-being of refugee communities. And finally, for our college-age students, competencies, professional development, and career opportunities that they hadn't thought about, that put them working with refugee communities or as refugee advocates. And so these are some of the mechanisms through which we addressed and responded to COVID. Next slide. Thank you.
Thank you, Dr. Morrison. That was very educational and inspiring for youngsters who would like to go into this area of work. I hope this has helped give our audience a good view of what's happening in Greensboro. We are by no means perfect. Our city has a population of 300,000, but we're trying our best because that's who we are. Thank you. I'm going to hand this over to Kunga, who's going to run the question and answer session.
Thank you, Chamu. Thank you so much for all our panelists for sharing all the wonderful information. I do want to encourage our participants to start dropping in their questions for our panelists in the Q&A section so that I can prioritize them accordingly. But for now, I think with the conversations that our panelists shared about, there was a lot of discussions around the importance of ethnicity-specific experience. So the dangers of aggregating all ethnic groups into one racial group, which I think is very important for refugee populations since their experiences vary by ethnicity, right? We can't group all African refugees in the same experience. We can't do the same with Southeast Asian refugees as well. So I have a question, and I think, Satta, I'll start with you. You specifically mentioned housing and employment challenges among refugees. So I wanted to ask if you could share with us which particular refugee groups that you worked with in MDA or, in your community that were most affected by COVID.
I worked with the Liberian community and also basically with the African community, because the African community, we have the Swahili, we have people from Nigeria, Ghana, and some of them, especially the Muslim, the Sudanese as well, Sudanese community, the Muslim population as well. So there were a couple of, I had this client where he refused to get vaccinated and then he was homeless. So he was homeless because he has an immigration issue where you have the huge backlog. His work authorization came in the mail to his old, where he used to live, his old address, and he could not get hold of it because he has to move and come down to North Carolina. This in Greensboro, he was in Salisbury. So he refused to get that. And when I reached out to him, he said, I have these problems. You have to set off my problem. I don't have a place to stay. MDA, with our partners, we were able to provide emergency housing for him for the period of 3 weeks. We were able to purchase his prescription drugs, and we were able to sign him for Orange County enrollment. And every time we have to follow up with him. And I have this other lady from our community that requested for Section 8. She could no longer pay her rent. So basically, in a list is you have to be approved to get on a list. It's another issue. So we can't even discuss that. So she cannot get on the waiting list. She has to wait for the waiting list to open before she can even be placed on the waiting list, before she applies. So these are problems. We have another client because from the Swahili community was impacted too by COVID Sahara. And he was out of job. He never had a place to stay. So these are things that happen, people, clients that we worked with.
Thank you. It seems like a lot of the art and support in an organizational level really helped the refugee community. So I want to ask the same question to Million. What about your community and your organization, how you tackled these challenges with your refugee communities?
So we are a resettlement agency. We are resettling refugees from around the world. It happened to be during the COVID time only. The people from DRC has been resettled, the majority of them, I would say. So, but the existing community, we have over 13 African countries, and as well as other Southeast Asian and Middle Easterns. The community is growing, and new refugees or parolees or asylum seekers have been ending up in our community as a result of, the existing community members, the infrastructure, access to language, and all those things. But I would say, everyone has pretty much been affected during that time with limited information, mistrust, lack of information. Like I mentioned, lack of information in their own language. Some actually, they don't even read and write in their own language. We had a great deal of interpretation issue. We couldn't able to really find, to able to communicate that information to every one of them. So I think the challenges for everyone, of course, there is a difference between different groups. For those who have been here for some time, have that community support. For example, the Sudanese, they've been here for a long time. There is an existing large Sudanese community. They've been very supportive for the newcomers. The same thing is true with the others as well. But the challenges for everyone coming to this area during that specific period of time, and it's two pandemic, just like Dr. Sharon Morrison said. I mean, you know, it was not only the COVID that we were dealing with that period of time, and the atmosphere was toxic. I mean, you know, being isolating, really. I mean, you know, the fear was there for people even to come out and to seek any services. So it was a big challenge that period of time. And so I would say, I mean, you know, everyone being affected.
Thank you for your response. So it really seems like the support, the need for support really varies based on, you know, the amount of time that refugees have been in the U.S. So in that context, Dr. Morrison, I wanted to ask you, you know, on sort of an academic end, as a researcher, you had been doing community engaged work during COVID, right? With considering all these restrictions and, you know, sort of threats, and knowing that refugee communities weren't as protected. What was your experience like doing community engaged work during a pandemic?
So it had its challenges, but I've been doing community engaged work long enough to understand that you pivot. And that is the difference. You pivot to the priorities. And so my priorities, one is training up the next generation of professionals. And number two is responding to the emergent needs. And while that tends to be a moving target during COVID, it was very clear what it meant. So, you know, one, as a researcher, two, as someone is training, three, as someone learning with the community during COVID, it presented more opportunities than it did challenges. And I say this because then you begin to understand when you theoretically say, this is how we get information to people, these are all the challenges, and we in academia rely on CDC or DHHS and so. And as Mr. Juma says, I'm listening to what's on the ground here. So one of the things that was very clear in terms of learning from and with the community was what were the best information channels? Not Fauci, not necessarily CDC, but what were the best information channels? And understand that people were talking to people back home. So I had students working on how were, for example, African refugee students who live in African refugee households or students who live in Asian origin households. How were those students dealing with the pandemic, and how was information being communicated in the household back home? And so those were important ways to pivot and understand. And once we understood that, then we also needed to know what's the channels, the best channels. And so then I could engage students involved in community engaged research in, for example, participatory work in designing social media messaging along with the communities to put a face and to put some, what I would say, what folks would consider reputable venue information coming out. So that for me it was a challenge in that way, but it opened up a lot of opportunities to really use the skills and background of those from the community.
Thank you. And I think, Dr. Morrison, I'm going to hold on to that answer because there's a follow-up question I think would is for you. Are there any efforts envisioned for compiling tools and educational materials that have been created by and for refugee and immigrant communities across the country using CBPR and other community participatory approaches?
Not that I'm aware of. I know that we have composites in the CDC on the cultural headings. I know that we have composites in Ethnomed and places like that. But as we do this, it'd be nice to have the tools and you know, we publish these things, but really they remain behind firewalls. And so in my work I'm making and in my co-authoring with community members, I'm making a concerted effort to use open access venues and place information there. In some venues, I'm aware some University of Pittsburgh does a good job in working and putting information back to, and using tools to put information back to communities. So it would be nice, for example, if at our state level, given that we've been resettling refugees for a long time, we sort of had these tools readily available based on lesson learned from 30 plus years of doing this. It would be helpful.
Thank you. Yeah, and to follow up with that, I think that's a really great question, because it really makes us think about how long has been refugee health research, right? How long have we been doing this work, and what is the evidence that shows that we've been doing this work? And I think one of the biggest challenges that I think our panelists talked about, especially Satta, Juma, and Million talked about, is this issue of language, because a lot of our communities are pre-literate, not just in English, but even in their own language. So when we have a huge barrier of, language literacy, forget health literacy or, health communication, the challenges are added on top of the already, health disparity challenges that marginalized communities experience in the U.S. And so when we talk about products, I think we really have to talk about spaces like this as well that counts for data, where we have people like Juma, who are directly sharing their lived experience with us, which are honestly true data, right? But due to the academic hierarchy, we aren't able to sort of publish it in a rigorous journal. But his lived experience, I think, outwins a lot of what could potentially be thrown out as products. And so I think that's just a context that came to my mind with that question as well. I think we had another question from the attendees. Andrew asks, here in North Carolina, refugee health is run through DHHS Refugee Office. As BIPOC, should they be under the Office of Minority Health and Health Disparities? I think I'll throw that question to Million or Satta or Dr. M, whoever feels comfortable answering that question.
Yeah, I'll respond to that one, actually. Yeah, of course, the Office of Refugee Resettlement has a contract with the State Refugee Office, which is under the Department of Health and Human Services. So they allocate their resources to able to provide the health service, including Medicaid and others, for the eligible period of time for refugees, contracting with the county health department. So I don't know, I'm not a policymaker actually, if that can be under the minority health and health disparities. That is what we have, and it's been working. I mean, so I don't know what else to say.
Could you or Dr. Morrison maybe share a little bit about what are the implications of that? What does that mean? If
you think about it, when we're in a state of civil rights where it's the black-white paradigm. Well, the state has gotten more diverse. So the North Carolina Department, of Health and Human Services, while it recognizes refugees as it's separate, refugees are also now under that BIPOC category. And so it's important because, one, you broaden the scope of data and where we can get data. I'm not just talking about numbers now, but a repository for best practices. And so that practitioners and people like Satta can access information and share what they have learned that works. The other thing if we move things or put things both places, it opens up, availability of being able to apply for funding that organizations need to do the work that they do. And it also helps rewrite the narrative about, we've been talking about barriers. Now let's start removing them. And so it opens up the possibility of engaging at the state level with those individuals to really solve some of these issues that we've been talking about and not wait till the next emergency. So to me, that by now we should be shifting in that direction based on all that COVID has taught us, that, you know, these are marginalized communities and they do fit under that category.
Millian, did you have anything to add to that?
I think Dr. Morrison's point, she has a good point. I mean, you know, and how to get that information. But there is this structure, I mean, you know, and of course, when you are serving everybody, it's really hard to disaggregate and able to really see what is the gap and identify and for further research. I mean, you know, the Department of Public Health is on the ground providing this service, and they are primarily actually have a contract to do so. But are they sharing this information, I mean, you know, with other stakeholders and service providers, and so that where is the gap to identify and able to do really more in terms of which group and what services. So I think that makes really a point, but having under probably the minority group, would that really solve that issue or really bring us more information that we really need so that we can address this health disparity as well? So I think that is something, an ongoing conversation to able to really continue to address that.
Thank you. And I think that a good follow-up question we have here is there a plan to develop a cross-community dialogue and accurate information exchange? Is this something funders can be approached for? Anyone feel free to answer to that question.
Yes, I would say that yes. We have already started doing that in the community without any funding. So if we have funding towards that project, that would be great to be able to hire a community health worker or hire people to be able to do the work. Because what I do realize from my own research I have seen is that the agency, refugee agency, and then the nonprofit organization, the nonprofit smaller groups, funding is one of the issues, is that you have the big organizations that have the huge funding, and the smaller organizations do the work, you know. And right now, one of the good things I admire in the city of Greensboro, that employers are hiring immigrants themselves to be able to solve these issues. So that would be a great opportunity for organizations to be able to step forward.
Dr. Morrison, did you want to add anything to that?
Oh, I think Satta said it right. I know that Montagnard Dega has received funding from, for example, local foundation or regional, the KBR Foundation, to increase health access. And their targets have been the Swahili speaking community, as well as Liberian community. So I think, and KBR started out recognizing that the Asian and Pacific Islander category is broader than what was out there. And so supported an initiative that brought together the Montagnard, Cambodian, and Bhutanese communities to work together and build capacity to address COVID needs in their community. And based on the success of that model, again, extended more funding or awarded the funding once it was applied for, they were awarded, to now bridge and work across other communities. So it is attractive, at least to our local funders. I'm hopeful that at the state level, this would be something that would be attractive to our, our state. I mean, it is in the best interest of the state to ensure that our communities, all communities, are doing well. It builds the infrastructure and the economic, and enhance the economic power of the state. So we would hope that that is attractive to funders.
And what about academic institutions, Dr. Morrison? Because I know, in Greensboro, I think UNC Greensboro is probably the only university that directly and heavily works with refugee populations. So, my question to you is, what is it about refugees or refugee health that doesn't seem to interest these bigger academic institutions or big funder organization to work on, health equity focused work on refugees?
Oh, that's a big question, and I can't speak for that. You're right. We've got these higher ed institutions along the same strip of road, in fact, and there's still a certain level of invisibility. And the irony of it is, our institutions are educating the next generation from these communities. So there's an awareness issue of how we define our minority or our BIPOC community. So that's one. Number two, I think it's really seeing things through a different lens. And we really have to understand when we say community, what our community is. So, Greensboro comes together every year for our folk festival, and we will showcase these kinds of, and other festivals, Refugee Day. But I think we have to have, our higher ups have to have a better sense of what the population and where they're located. And I think that's one. The other issue with funders, particularly at the federal level, I think, is more recently that they're recognizing that going to communities is the best place. And so even a recent grant announcement from the NIH was designed to have communities as the primary investigators and then academics as allies or secondary or support. And I think that is a great start. How this will play out depends on, the reality of everyday life and how programs that are proposed really fit in refugee community life. So those are some answers I can give. Academia has some time, it needs to get caught up with our communities and sort of see our communities very differently.
And Million, what about your organization? What is the funding structure or your funding challenges that you've experienced in terms of being able to do the work that you need to do?
Well, the need is staggering. I mean, when you see new demographic coming, there's a different need. I mean, so the funding is not matching to that needs, and the funding is not even close to, able to help these newcomers to integrate well to the community. And one thing, a participant mentioned on the chat is we don't even know how many people are living in our community. Segregated and different. We say that, okay, we have a large Sudanese community in Southeast United States live in Greensboro, but we don't know how many. And we have a large community just arrived from Afghanistan. We don't know how many actually. And so I think we have that issue, trying to present the accurate information and the number of people, these are a highly motivated and contributing member of the community, but how we can really able to help them to integrate well. There is a challenge. There is really continuous kind of challenge. So there's no enough funding in the first place for those programs that's been identified to provide this service. And also there's negligible almost, to able to identify what is the new need for each community. Each community has their own need. For the people who's been here more than 20 years and those people who just got here as well, they have a need, but that need is not addressed or not be really acknowledged. So because everyone is trying to fit them, to one kind of lens. So that is the issue we've been dealing with. And while we are dealing with this, there are new arrivals coming into our community, which is adding a pile. So that is the vicious cycle we are dealing, year in, year out, and it seems like nowhere to go.
Yeah, thank you. I mean, I think Satta also mentioned the important work of grassroots organizations, but funding is where things really start filtering out. So I think what we can take away, one thing from today is, the importance of funding structures and how it really impacts this important work. So I have one last question, and I want to throw it out to Juma. Juma, what do you want our attendees and this larger U.S. community to know about refugee health? What is it that you want them to know? Juma, you're muted. There you go.
So can you repeat? May you repeat your question?
Yes. So what do you want our attendees and maybe the larger U.S. community to know about refugee health? What do you want to say?
I would like to say that the most of the refugees, they are coming from there, they're really in need. And we hope if there is a funding from the government that can help the leaders of the organization that can participate to contribute what they have. Just they can sacrifice with their efforts, as well as if they get some materials that can give them to settle their resettlement, and especially side of jobs and the educations, especially vocational trainings is the most important for the refugees, though they came from there. And the language itself also, it needs to be supportive, because the language is the biggest barrier that lead refugee couldn't be able to communicate in different directions. And also transportation, especially a refugee, since I have experience on my own, since I came here, I came without even a single coin, without a color, without anything. Then I get a support. I have a kid, I have a wife, I have a lot of stuff around me. If I couldn't study before knowing English, it could have been hard for me but I'm thinking, what about those people, they came there without any language experience in English? So even I myself, I face a challenge based on economically, workplace, who's gonna stay with the kids, how can kids go to the school, who is gonna be translating them there into the school, newcomers or wherever. So it needs a real fund for the leaders of organizations that they can try to establish to get a more what do you call a more people that can try to help them too, just because it is not simple job that when you are trying to settle to somebody into the place, it looks like you have a small child today, you want to rise up. It's not easy, right? It's the same as, it's true. So you need a lot of things to make somebody settle and stand and move and do everything, and then you can leave him alone. He can able to do what he can do.
Thank you, Juma. Thank you for sharing that. I think it is really important to talk about the challenges that new arrivals face in the United States. So that's all the questions I have for the panelists for today. Sharice, if you could bring the slides back up.
Thank you.
Thank you so much, everyone. Please take 2 minutes to complete our short evaluation form that has been shared in the chat. Please click the link and do so for a couple of minutes. We will allow all our participants to complete the evaluation. If you could do it right now, that would be great. It's very short. Therese, if you could bring the slides back up, I can move forward with the rest and close out. All right, so thank you, everyone. Please visit our website. Give me a second, please. I apologize. Yes, so thank you for your time. Please visit our website and sign up for our newsletter for updates on partnerships, webinars, and other events. Next slide, please. Lastly, we just want to say that we're celebrating our 25th anniversary as an organization. For the rest of our 25th year, we'll be putting on educational webinars on our projects and partnerships. And if you've been working with CCPH, please share a comment, a moment of celebration, or partnership story on our webpage. Thank you again and hope you have a wonderful day.